Some people do not feel comfortable telling their story through a narrative vocally, and for some people they've used storyboards, so collecting pictures, or one guy actually cut headlines out of newspapers. And at first when it came in, I was like, oh, this feels a bit like a horror movie, you know, with death threats. But actually, when he put that up, it was really impactful, but he didn't want us to photograph it, so we haven't. But this one gentleman who'd been under long-term care, actually, he'd got head and neck cancer. He came in and he just showed that one picture of a tractor. And it was a bit like a kind of show and tell, but he didn't want to talk. But the staff were saying, well, that's a nice tractor, thinking, what's this got to do with his healthcare? And I just said to him, do you feel able to say why you bought the picture of the tractor? And he said, he said to the staff, do you want to ask that question? They said, yes. And he said, well, that's the point. So we sat there for a while. He said, I'm a farmer. And none of you know that, and I've been coming here for nearly 5 years. And he'd got throat cancer and he'd got a tracheotomy, and so he had humidified bibs. And he said, every year during harvest, I ask you for more humidified bibs because I get through them really quickly. And you say, no, I can't, because I can only have a certain amount. Will you this year give me more humidified bibs? And they went, yeah, why didn't you tell us? He said, I tell you every year. I ask, and you're not listening. You know, one picture says 1,000 words. So even one picture can be really impactful for people. This second set of pictures was from a gentleman who was accessing mental health services, and he'd had a crisis, and he'd come in. And then he was going into an assessment, and he walked into a room, and there were all these, what he described as grey suits, sitting across the other side of the table. And this was a gentleman who'd been in trouble with the police before and been to court for offences to do with drugs. And he said when I walked in, it just felt like a courtroom. And actually that setup had been like that for a number of times, and when we looked back, there'd been a number of complaints from patients about it, but the story made them take the table away and just have more informal seating. So formal complaints, and we dug out the letters that were sent back. It was like, you know, thank you for your complaint. We're really sorry that this made you feel like this, and we will endeavour to make you better, and something like that. But nothing changed, but the story made it change that day. So still photography is very powerful. You'll see, I know in Canada there's quite a lot of films of patients telling their story, and we use lots of films. I have to say, film, I think, is one of the most powerful things. You know, a patient saying something on film, everybody is sitting there looking at it, and for me, it makes the job of an improver quite easy, because some of the difficulties of being an improver is trying to convince people about the need for change. The film is a gift. You just sit there and people are watching the film, and instead of then having to say, okay, so now, you know, what might our plans for change be? You know, people are getting up and saying, okay, this can't happen anymore, we've got to do something about it. It really speaks to people in a different way. Now, there is some difficulty with film because, you know, it takes time. You need to get film cameras and things like that, and I'll talk a little bit more about that later. But it is more time consuming than some of the other medium, but actually it's worth the effort. The other thing I mentioned was observation, in the way that Deborah does it rather than me. And, you know, it's about taking a step back, seeing a place that perhaps you're working in every day, or that you've seen quite often, with a new set of eyes, and understanding what really happens there. It brings new ideas, and it kind of challenges your perceptions about things. And there's an organisation called IDEO, who are mainly based in the States. They're a design organisation, and we did some work from them, and they had this stuck on a wall, and I love it. People don't always do what they say they do. People don't always do what they think they do. People don't always do what you think they do. People can't always tell you what they need. And that's really very apparent in healthcare, because healthcare staff are so inventive. They work around, and then they fix things, and then they don't know that they need something. And you pick that up on observation. And observation lets you find out what people really do and really need. And it's not that any people are trying to tell you lies, but actually you observe things, and you're seeing things, and you're seeing people do things that you know they shouldn't be doing in that way. Might not be harming anybody, but you're thinking, why do they do that? And then if you said to them, oh, could you just describe, how you did that? They'll describe it in a very different way to what you saw. And so that's part of the power of observation. So we were, again, it was a challenge given to us. People are not using the hand gel, so make a poster to make them use the hand gel. Okay, there's already posters, so this is our department's house. So there's already posters, and we don't think that'll work. Well, make it really sexy so it works, not like any other poster. And we're like, can we just go in and try something else? And they said, okay, but do it quickly. Anyway, we went in and we were basically observing wherever there was hand gel. And this was quite a while ago, so it's changed a lot. But what we saw a lot of is hand gel dispensers that were completely inconspicuous. They've got nothing around them that said what they were. Quite often they were very high up on the wall, so normal-sized people like me couldn't reach them, and certainly children couldn't, and a lot of elderly people couldn't, and nobody in a wheelchair could have reached the hand gel. And there was nothing around them where people who were, particularly clinicians who were carrying things, could put the things when they were using the hand gel. So what we saw, particularly with clinicians, they'd be walking along and they'd try and get the hand gel and got a load of notes and trying to get it, couldn't do it. So put the notes on the floor, use the hand gel, and scoop the notes up. And when we said to them afterwards, oh, just tell us a story of you going into that ward. Do you think they said they put the notes on the floor? No. No. So people can't always tell you what they're doing, but you observe it. We also saw on a number of occasions where there was an official notice that there was also a handwritten notice saying, please read this official notice. So absolutely ridiculous. We also saw staff, but actually more so relatives, more frequently using hand gel as they left the ward than they did when they came in. And the big anxiety, particularly for relatives visiting from outside, was that they were carrying MRSA in, and we needed to them to use it both times, but more so on the way in actually. But their perception is, I'm clean, this ward is dirty, I only need to use it on the way out. The other thing about notices as well, in England, all the notices were on the walls. And so if you observe people walking down corridors, do they walk like this? No. They walk like this. And we did a test of putting notices, sticking them to the floor or to the ward door, and the use of hand gel went up by about 50%. Because it was in front of them. We did big chevrons and said, it was hand gel, and the chevrons got closer, and then it just said stop unless you use the hand gel sort of thing. And because it was on the floor, and that's where you naturally look, it was very impactful. It's quite difficult on the floor because there's problems with the cleaning and stuff. So, but it gave us an insight that actually putting notices on walls is not necessarily the best place for them, and there's more and more on ward doors now. We also were sitting in a waiting area of the clinic, and we're just observing people, they're in the waiting area, their name was called out, they went round, and it was kind of in a horseshoe shape. They went round, and suddenly some of them would pop up in front of the waiting room like this. with the nurse, and they'd be asked to take their shoes off and get on the weighing scales. Like this, and come to the waiting room, face down, facing you and on the weighing scales. Interestingly, that had not come out in any of the patient's stories. And we were working with this particular group, and when they'd come out to the clinic saying, oh, how was that? It didn't come out. And I just said, well, I saw you were weighed. Virtually, before I could get that last word, weighed, out, they all said, oh, that was so terrible. But they hadn't volunteered that, but I picked it up by observation because I thought, there's no way anybody's getting me on a pair of weighing scales in front of the waiting room. So that was me thinking about my perception, but I just said, you know, how was that? And we got a lot of very negative feedback, and mainly the women mainly said it was very undignified, and that they didn't want to do that. Everybody was looking at them because people in the waiting room had got nothing else to look at. So there was an event going on here, and some women were very anxious in case people could see how much they weighed. The men were less bothered about how much they weighed, but they were worried that their wife would kill them if they hadn't got clean socks on. Or they got holes in their socks or something. But in any way, it was undignified. It was felt to be undignified. And then, as we were talking about this story, and there was only about 5 or 6 patients, but they all were telling the same story, the staff there and then said, well, what can we do about it? And the 5 or 6 patients and the staff went back around into the clinic area, and they found a place that was still in the corridor, because the nurses needed to do that before they moved the patient into the consulting room. But it was in a corridor where nobody else could see them, and so that was much better. This was at the end of the clinic, at the end of the day, and we all kind of packed up and went home. Came back the next day, and by mid-morning, about 10:30, in this purpose-built clinic, every set of weighing scales had been moved because they were all in the same place. Every single set. And nobody told them to move them. They had just heard the story. Now that seems like a very little thing, but for patients it's part of their experience that makes a difference. The final one I just want to share with you about observation is around language, and again we're back in a clinic where patients had got cancer, and we were in this clinic and we knew out of the people going in to see the consultant, basically we're telling you the diagnosis, and there were a number of patients who we didn't know which ones, but we knew there were a number who would have confirmed that they had got cancer, and some that would be confirmed that they hadn't got cancer. So we were sitting. The reason we were there was because the nurse, telling her story, said she hated it when she had to escort the patients who'd been told one thing or another, usually the ones who'd been told they'd got cancer, across the waiting room into a private kind of counselling room. And she didn't like doing that. She didn't, she thought it was horrible for the patients, and we were just kind of observing that to see what we could do. And we were all sitting there watching these patients come out, and then we'd pre-arranged to have a little chat with them afterwards. And my assumption was, you'd get to see people who might be distressed, and we were ready there with tea, because you give everybody tea if they're distressed. And we were just ready sitting there, and they could go to a quiet area and then choose if they wanted to talk to us or not. People were coming through, and they were having their cup of tea, and they were looking okay, and I was thinking, okay, I was making a diagnosis, they haven't got cancer, they're not crying, they look fine, they haven't got cancer, they haven't got it. And we got to 3/4 of the way to the clinic, and I'm thinking, okay, all the rest must have cancer. No. We were talking to the patients, and they didn't know what their diagnosis was. I thought, this is really strange. So we said to the nurse, what's going on in the consultation room? And I said, has anybody been told they've got cancer? Oh yeah, they have. None of the patients knew. So we talked to the doctor and said, there's this issue here. And he said, no, we've definitely told some people. So we said, so he knew what we were doing, and we said, look, can we come back the next time we have one of these clinics, and can somebody go in and observe with you if we get a approval from the patients. Yeah. So we did it again, and these are some of the words that we wrote down. Blisters, lumps, ulcers, polyps, warty things, necrosis, lesions, naughty tumour, aggressive, progressing, and precancerous. In this clinic, not once was the word cancer used on its own. Precancerous was used, but those people who had got cancer were not told they got cancer. And when we shared this back with particularly the consultant, he was absolutely devastated because he thought he was saying the word. And he was saying, God, how long have I been doing this? You know, and observation, you know, we learned something from the observation and then needed to go and do some more in-depth observation that was slightly more intrusive, but actually made a big difference for patients. And he then got himself filmed and retaught himself to say the word cancer. You know, he's a fantastic guy. Patients loved him, really kind. He couldn't say the word cancer, and he was a cancer. So, you know, observation, you know, and he truly believed he was saying the word. And the nurse in with him truly believed he was saying that word, but he wasn't saying the word. So, you know, if I'd have said to them, oh, describe your process, we wouldn't have picked that up. But through observation, we did. Often, when people are doing any improvement projects and experience-based design is not taken away from them, they say, we haven't got time to do this. And so we often use observation in other situations, and the Productive General Practice Programme is a programme aligned to releasing time to care. The basis was on releasing time, but actually the GPs that we were working with didn't like that phrase, they preferred the word productive, so we called it that. But in our early observation, what we were trying to do is to understand how both doctors and nurses in general practices could release some of their time, because in England, GPs have just been given a whole new workload because they've got all the money, virtually, and they are now purchasing services, they are commissioning care. And they were saying, we haven't got time, you know, we're busy doing clinics, which they were. And we used it, and particularly, this worked for the GPs as well, but this example is from, you know, the back office, if you like. And we observed what happened to this pile of notes, and how long staff spent looking in this pile of notes for diagnostic results and for everything. And on average, we observed for about 2 weeks on that. It took every day up to 2.5 hours. And sometimes it was half an hour, and sometimes it was 4 hours. Somebody going through the notes, looking. Now actually, then we said, let's put these notes away. It took 45 minutes to file the notes. And then you know, it saved quite a lot of time. So observation can be used really effectively for lots of things. And you know, the back office staff were always moaning about not being able to find anything, and we haven't got time to file the notes. And like, you are wasting so much time. Let's file the notes and just move on, and it makes a difference. So, you know, actually, observation is really powerful in lots of ways. So just a couple of comments from people working using these approaches. Listening to the patient experience does open your eyes. You pick up on things and you think, oh my good, how could we do that? I think he'd been doing some interviews there. He's from New South Wales. One of our consultants, this goes on to what I was saying earlier, you know, sometimes we can invite people onto a committee and that's the involvement box ticks, but actually you need to do much more than that. Patients are really powerful on committees, but you need to do that as well. One of the comments that led us on to doing something else was the difficulty of running this project in the ED. It was the short turnaround times, and you know, people were finding it difficult to get stories from patients in ED and areas like day surgery. And so one of the tools that we developed because of that is this experience questionnaire. I think you've got a separate, or you'll be getting a separate handout of this. But basically, this very loosely gives a high-level process. So this is actually a day surgery one. Arriving, checking in, information waiting, going to theatre, recovery, check-up, and leaving. And under every high-level process step, there are kind of pseudo-emotion words going from I'm happy to I'm sad, you know, in between. These are words that we picked up from what patients were saying. But different sites change these a little bit. And then underneath there's a box, because those emotion words are there to prompt patients to identify how they feel. And if one of those words doesn't suit them, that it doesn't represent what they feel, they write it in the box below. So this was a gentleman going through day surgery, and you know, when he was arriving and checking in, he first said, I'm worried, but then thought, oh no, I'm going to add to that, I'm actually very scared. So he wrote that. Going through, felt very comfortable going to theatre, didn't feel any pain, less scared, terrific staff. Then in recovery, shaky and relieved, no pain. These questionnaires are being used a lot, and often we use them early on in a project to try and identify if there's any particular areas that we need to focus on. So they're a kind of easy, quick win, and they also give you volume. Yeah, and some people use them routinely. You know, some day surgery units or EDs just use them, you know, every Wednesday afternoon or changing days. So these are useful for when you need quick feedback. Although I know one of the things with any questionnaire, anything you're asking a patient to fill in, I personally believe you need to do a little bit more than just leaving them in a pile or giving them to them. I think, you know, you should try to aspire to just say something about what the questionnaire is for, and try to, when you're discharging the patient, say, oh, have you had time to complete that questionnaire? Would you mind doing that? If they don't want to do it, that's fine. But I know in places there's been some difficulty with returns. I think you kind of have to ask for them. You know, rather than just leaving them around. But certainly there's lots of very positive feedback from these. Focus groups is another way that you can gather information and experience. Really good, but you've got to run them well, and you've got to really make sure you do something from the feedback that you get. And just before lunch, I'm just going to get you to do another exercise. I hope you notice we want to look at emotion words that depict how I'm feeling, because that's really important. Now, you know, if you look in the dictionary for emotion words, some of the words that we might categorise as emotion words might not be true emotion words, but they're words that help me to understand how I'm feeling. So I'm going to get you to watch this film of a lady called Sheila. And Sheila was one of the first patients we worked with, and this film is a snippet because the whole film was about 45 minutes long. But this particular set of snippets actually shows something very distinctive that we see often. Now, Sheila knows that and has given permission for her film to be used for the purpose of service improvement both in England and internationally. And every time I use it, I send her a postcard and say, I'm in Canada or I'm in London. But I don't have to tell her where I'm in. Sheila, so we've been using your film today, and she loves getting the postcards. So I want you to get a piece of paper, and as you listen to Sheila's film, and it's only about 2.5 minutes long, I want you to write down anything that you hear that could be considered an emotion word, a word that makes you think, oh, there's an emotional response there. Okay? Now, Sheila's got quite a quiet voice because she's got throat cancer. So we've tried to enhance that, but you just sometimes have to listen quite carefully.
I found it a very dreadful clinic, and if you put things in perspective, because you saw people who had the most dreadful surgery and operating their voice boxes, and it filled you with horror. And it was indoors, so you couldn't see whether it was raining or the sun was shining. And if you were down there, say at 10, you might have to wait until 12. And on this particular day, we had an appointment at 11, and I think we got in to see Dr. Kuchard at 10 to 1. Now the waiting is terrible, but when it is your turn, that appointment is just for you, and it's as if there is nobody else out there. And you can ask all the questions, and everything is said to you so gently but professionally. And all of these people I found were so kind, and their overwhelming effort to help, and I felt that everyone was doing their best for me. But not only that, but in a professional and such a kind manner, and that everyone really cared. And then I met Mr. Chan, who welcomed me, called me by my first name, which I did appreciate. She did both all about me, and I really took to him.
So what words are you hearing? Horror? Dreadful? Terrible? Overwhelming? Kindness? Gentle? Appreciative? So what this piece of film shows is what we often see, actually quite a balance. Even if you get some really strongly negative emotions in a patient's story, we often can find some positive in there as well. And we use this film a lot for training, particularly for staff, because many staff are very fearful of only hearing bad things about the care they provide. And that is not nice, is it? But, you know, it very rarely happens. And especially if you're talking, you know, to 4 or 5 patients, there's always good. And one of the benefits of film is you can see Sheila's kind of facial expressions as well, and how she is. And at first she's kind of looking down and, you know, very sad looking face. And then as soon as she starts talking about Mr. Chan, who she fancied, you know, her face completely lit up, because Mr. Chan was a person that, you know, she felt treated her really well, and it almost, all that terrible, dreadful waiting that had gone on almost disappeared with a puff, because actually Mr. Chan treated her like the person, said he knew all about her, it gave her confidence, it was really nice to her. You know, some patients don't like being called by their first name, but Sheila does, and so she really appreciated it when he talked to her and addressed her by her first name. So, you know, we always, the picking up of emotions is really important, and it's a major part of the next stage, which we'll do after lunch, which is about understand. We're constantly tuning in for those words, and we're thinking about where those words are in the point of the process of care. So, you know, the dreadful, horrific, negative emotions were all around the waiting, that part of her journey. The very positive emotions in that individual consultation she had with Mr. Chan. So we could immediately start to look at what's really fabulous for Sheila in her consultation with Mr. Chan, and how can we build on that, and what's really going wrong in this waiting, and how can we start to put that right. So it immediately points us to areas in the process that we call touch points, where an emotion can be linked to a point in the process or the patient's journey. That's a touch point. And we can pick those up, and it's touch points that we work with, both negative and positive, to learn from in both cases. So this morning we set the context for working with patients in a closer way. We gave some stories to try and illustrate some of the impact, and then we went on to the actual EBD approach, and we, just before lunch, we went through the capture stage where we highlighted a number of tools and techniques. And I said to you that I would come back on filming, because, you know, I think as you saw from Sheila's film, but I know a lot of you have all got some film of patients as well. It is really, really powerful. It is undoubtedly more difficult than using any of the other tools. However, actually, where some sites in England particularly have done really well, is they've reached out to patients and said, can anybody help us with, particularly with editing of film, or even filming? So often they've had help that way. But in addition to that, a number of other organisations, if they've got a local college or university, you might find that there's a journalist course, a photography course, a filming course, and actually quite a lot of them have built relationships with their local university or college, and the students have been able to come and help and use it as part of their own coursework, and that's worked out fantastically well. One slight downside on that is that, well, I don't know if it's the same here in England, we have to have anybody coming to work with patients in that way who's not a healthcare professional checked on our Criminal Records Bureau. And that's quite simple, apart from it takes quite a while, sometimes up to 10 weeks to get what we call a CRB check. But actually, if you can think ahead, and if you think that in your organisation you want to do a number of films, you can develop a relationship and get that planned ahead. They are undoubtedly, I think, one of the most powerful things, and actually their use. So I've been using, that's a terrible thing to say, but I've been showing Sheila's film now for nearly 8 years, and it's still as impactful as it was when we first saw it, so that many films, you know, are really useful to show again and again. And I was talking to some people over lunchtime, and you know, some people are using them in induction and things like that. So you know, they have multiple uses, so they are worth their weight in gold. The other thing I'd say about the capture tools is I often use more than one. Invariably, I would encourage anybody to do observation. I think observation really, really helps you understand what's really going on. And then decide on your patient group, your consumer group, what other tool or bunch of tools might be best. It might be the Experience Design Questionnaire, and I think you've got them on your tables now. There's some more here. Is often, again, a useful tool just to get a sense of where the problems are. You can also print this out, especially when you've got the slide set, as just an A4 sheet that goes that way, which is more handy if you're going around talking to patients about it. And in addition, it's been designed very specifically so you can decide what the process steps are on the top. So, you know, these are all changeable, you can add, take away. So you can make it relevant to whatever area you want to talk about. This one, as I mentioned, is day surgery. Yeah. But you can do, you can adapt it to the ED, to outpatient areas, to ward areas. And we've used it in multiple ways like that. So I tend to use observation a lot. I often use the Experience Questionnaire quite a lot, just to give me a bit of a sense where to target the more in-depth conversations and filming and things like that. But you know, you just have to decide what's good for your client group. Are there any questions or comments or challenges from this morning? Yeah.
Just a question about this tool. Have you had any experience in using it over a longer period of time, say a couple of weeks, a month, that kind of thing? Is it ineffective?
Not for that tool, not for one person. I think we'd use a journal or a diary type tool for that. This is more useful for a point in the process, really. Yeah.
Thanks.
Have you used some of the tools for observing care in the home?
Actually, there is a site doing that right now. We've got we've got a program on which is about spreading patient experience methodology, and there is a team using it in the patient's home right now. They're due to report out at the end of January, so you know I don't know how they're doing. However, we have been using it in residential care home settings. And it's worked. It's been adapted. We've adapted it a bit for that, but that's worked quite well in residential care home settings, which is not exactly the same as your own home, but it has some similarity. So I think it is quite adaptable, but I think try it and you see. Any other questions from the capture session this morning? So you're all going to use some of the tools. Yeah, good. So the next three, that capture section is by far the biggest in a way, and that's, you know, if you're using this in your project, that will take you the longest time and probably improve the next longest just because there's some timelines. But I'm going to talk about understand the experience now, so the second bit. And this morning I was talking a lot about emotion words. And understanding the experience is about really taking things that you've learned, the insights that you've had through your capture activities, particularly trying to focus on anything that you know, makes you think is an emotion, because that's really important. That really helps us understand the patient experience. And then you need to link that emotion to the point in the process that emotion was evoked through. So if you think back to Sheila, you know, the point in the process where she had all those negative emotions was actually around waiting. And that was her waiting in a clinic. And then she had lots of positive emotions later on when she had the consultation. And, you know, if you're using the experience questionnaire, you can, you know, people will bring a kind of emotion word or make their own up. And you've got it, it's right there, next to the specific touch point, whether that's, you know, going into theatre, I'm scared, coming out, I'm shaky but okay, information giving, you know, that was good for me. So when you use the experience questionnaire, you've kind of got a bit of a map there that you can link it to. When you're doing interviews or observation, you need to be thinking about at what point in the process is that patient or client talking about when these emotion words come out. And if you're listening, what we would typically do is kind of listen for those emotion words and be making a map as we go through. Patients are often quite good in methodically telling their journey, but sometimes they go backwards and forwards. But it is about making that link with where you hear they're experiencing something and they're articulating that through emotion to the touch points. And then we make sure we map them. So this links into our improvement knowledge around process mapping. And we would just map those emotion words and cluster them around the point in the process, the touch point. So here, arriving, you know, you might have one that's quite positive, I'm feeling safe, and another one that's saying, I'm angry. You know, that's a trigger. Okay, why is that person angry? If you go back in their story, it's probably because they haven't been able to park anywhere or something like that. You know, you're going home delighted, confused. You always get a range, or I'd say 99.9% get a range. But actually, you'll get a predominant focus, be it negative or positive, and that helps you work on it. So really, understanding the experience is about, you know, picking up the emotion words, using a map, linking the emotion words to the map. And so you'll start to build something like this. This is a person coming into a clinic, and they're arriving at the car park. We've got positive emotions just in this illustration at the top, and more negative emotions in this illustration at the bottom. So frustrated as they arrive at the car park, but then the more in-depth discussion, you can get more understanding. It took ages to find a car parking space, and then I found it was a 15-minute walk to the outpatient clinic. How frustrating. And actually, most patients in England are worried. They come early because they know they're going to have trouble parking. And then what they worry about is, because they put money in their slot, they don't know how long they're going to be in the clinic, they don't know if they've got to get the right change to go back and fill in the parking meter before they get seen. It really makes them anxious, But you have your link, so it is about getting an insight. Where are we feeling negative or positive emotions at particular points in the process, and then getting more in depth. Okay, what's really caused that? What's the story behind that? And that's another reason why you need to use multiple methods. Now, I'll just show you. This is upside down because it's from New Zealand. I mentioned before, I've been doing some work in Christchurch in New Zealand, and Christchurch is the place where they had the terrible earthquakes 2 years ago. And basically, it's a beautiful place, but very scary. I don't like going there very much, and I go there quite a lot. But the hotel I'm staying has got scaffolding poles holding the ceilings up. The hospital that is left standing has got scaffolding poles holding the ceilings up, and in places you can see through the wall and see light, and that is their safe building for patients. So they're taking the opportunity because they've got to develop a new healthcare system, and so what they're doing right now is some baseline mapping. And they're mapping what currently happens, and they're mapping a number of processes that actually mainly go through the ED and up towards, but they're doing kind of lead mapping and patient experience mapping at the same time. So the top bigger post-it notes are the lean type mapping. There's more detail than this. This is a very high level one. And then underneath, and these smaller post-it notes are clusters of emotions where we've been talking to patients and got emotion words. So we can see the yellow here are positive emotions and the blue are negative. So they're starting to build that. And then from that, basically, they've then drawn out some initial themes. And in this, there's quite a lot of themes across the whole process around communication. There's quite a lot of themes across the whole process around time, and it's mainly time waiting or times I think something would have happened and it hasn't. They've created a staff cluster where, they've got fantastic positive things like can't fault them, staff are marvellous, really make a difference, to quite negative, growly doctor. There. Food, very negative. They hate the food. The food in New Zealand hospitals is really poor. Getting around, this was for people who were discharged from the ER but then had to come back into clinic. Quite negative there. No, positive, sorry. So that was easy, good signing. They've got lots of emotions generally, and they've got a whole board full of these emotions, sleep and family. So they've clustered from that high-level process mapping, then they've clustered in a different way, and many people do that. Some will just keep their high-level process mapping with everything there, and that's quite important. You need to have that there in your face so you can build on it, and other people theme in a number of different ways, depending on how they want to do their improvement. So that is just an example, but what we have seen is this so-called soft methodology linking in really well with the so-called harder methodology of lean. And we use it a lot to augment the lean methodology of really understanding processes. And there's a hospital in England who aspired to be the first LHIN hospital, and I was trying to get the chief exec, who I knew quite well, to use EBD, and he was going, no, it's rubbish, and we already do value stream mapping, and that's all we need. And I kind of gave up for a while, and then I found out he'd been using it. So I went up there and said, show me what you've been doing. And actually he said it was the missing piece. Even though they'd done value stream mapping, it did not give them the richness of what was happening that EBD did. And they've been using it a lot with staff as well. You know, staff are changing the process, so it worked really well. One big piece of learning that we had when we've mapped and been focusing on the patient's journey is that typically, as clinicians and managers, we map for our span of control. So, you know, if we're in an outpatient clinic, it might be the patient arriving in the clinic to, you know, when they leave. When you start talking to patients, particularly when you're having in-depth conversations about the story of their journey, where do you think it starts and ends? Not there. You know, it starts like with the other one, with often starts with, did I get an appointment at the time and date that suits me, or have I had to jiggle things around? Because that can be quite frustrating. Do I know where I'm going? Can I get there? Can I park? And often there's all that, of course all that's gone on before they even get to where any interaction is going to happen. And equally, a bigger void, because that's quite a void, they're on their own really. A bigger void is when they leave the clinic or leave the hospital, and we give them information, and most of the time it's absolute rubbish. And it's rubbish because it's not written in a way that's really understandable, or it is wrong. And I was talking to Paula last night, and I had a minor. So I know the health service. I've been in the health service since I was 17, and I had minor surgery and day surgery a couple of years ago. Got the information. Felt dreadful when I got home. I thought there's something not here. Rang the number on the information, but oh no, you're nothing to do with us now. It happened to be the ward. You're nothing to do with us now. Ring your GP. So, oh no, it was ring this other number, and that happened to be the surgeon's secretary. No, well, you can't speak to the surgeon. Like, well, I can because he's done something and I'm sick. No, well, you can't. You phone your GP, so she wouldn't let me speak to the surgeon. But because I knew the chief exec of my local hospital, I just rang him up and said, for goodness sake, sort this out. But if I'd have been any other patient, as it happened, I was infected. If I'd been any other patient, I'd have got sick. And, you know, it was because they put lots of information on there that it didn't work. It didn't work. It didn't tell me what I needed to know. Also, we tend to write information at a level too high for the basic understanding of the population. And I know many countries are looking at literacy at the moment. In England, we've been asked to try and write for the age of somebody aged 6 as being the average literacy age of our population. And yet we're writing from the perspective of the 20 to 30 to 40-year-olds university educated people most of the time. So there's no wonder there's a disconnect. And it's that gap, particularly when people leave one part of the service and don't get picked up in the next part of the service, which we've discovered causes the most devastating negative emotions. Really sad and frustrated and upset negative emotions at that area, and it's caused us to do quite a lot of work in those areas, particularly around information and where people go. And who writes the information leaflets? Not us. We ask the patients to write them. Now, there's things that we might need to put in from a legal perspective, and we need to work those in, but we get the basic copy written by patients for patients. not just one, a number. But again, you know, what we've got to remember is some of these patients, in one project, the patient was a professional writer, you know, and actually had really good understanding of how to write for somebody's understanding. So, you know, we can use patients to help us in that way. So basically, understanding the experience is quite simple because you've done all that work on gathering and you often have a lot of data, but it's really about those simple things. Find the emotions, find the touch points, the points in the process where those emotions happen, and start to map them so that you've got a really good picture of what's happening. And then you can work with the patient. If we go on to the next stage of improving, you work with the patients to say, so what are we going to do next? And that's what Paul is going to take you through. But I'll just pause for a minute. Any questions on that understanding? Just before Paul starts, I'm just going to take 2 minutes. So can you all stand up and find one other person and stand facing them? And move out here. Now the best thing about that is you're all on film. So that was just a little energizer because you were looking a bit dopey. So I thought I'd wake you up with Paula. But again, it's another trick I got from school teachers who teach children in the age range of 4 to 6. Right, we're going to go to Paula. The magic age, Paula, please. So we get from Lynne to me. Thank you.
So we're going to move now from those first 2 big pieces, which are the capture and understand. And those are really the different pieces because I know that all of you are involved in improvement work. And now what we're going to do is demonstrate how these pieces fit within our normal improvement work. And if we think about it, sort of project startup and then the diagnostic phase that we usually do to really understand the problem. These capture and understand tools are part of that toolbox for really understanding the problem. And I'm going to steal a phrase from Lynne that she shared with me last night because we always try to get people to slow down and really understand the problem so that then once you start identifying solutions to address the problem, they're actually the right solution and not, then if we hurry up and implement things that aren't really addressing the right problem, we wonder why we don't get the results that we're hoping for. And the phrase that Lynne shared with me last night was, stop before you start. And I thought that was great. I think that they're using that for in a publication, but it really is captures what we try to do. And so I just really wanted to put this into context and say that these 2 critical sets of tools that Lynne's just created the methodology for are really part of that big picture diagnostic phase of understanding the problem. And now what we're going to do is fit that back into our Plan, Do, Study, Act basic foundational model for improvement and say, we're now at the stage of, we understand the problem, what are the change ideas that we're going to come up with as a result of that different perspective that we now have to start to resolve the problem. So the first thing that I just wanted to run through with you, and you're going to, all say, we know how to plan events. We know how to plan events even before we learn how to do improvement. And I know that you're all very skilled at that. What we're just going to focus on here are a few of the tidbits that are a little different as a result of the fact that we're working with patients and their families. And we are doing some work that's slightly different because some of these events, even though we may have gone solely to capture the experience with patients, we may have done that separately with providers. And part of this is where we join together as a team, and so some of the things that we do can be quite different. The first thing is when we have providers and patients and family members coming into the same room, make sure nobody has a headphone. because we want to make sure that we're leveling the playing field, that everyone walking into the room is an expert in their own right, coming from with their own expertise from their own perspective. And immediately, if we as providers have our name badges on, we already sort of put up a barrier. So that's one sort of tip to keep in mind. The other is to plan the date well in advance, and clearly, if we're being respectful of staff, we're going to do that as well. It's one of the principles of LHIN, is being respectful. But in particular, when you're dealing with patients and families, they're otherwise gainfully employed or involved in all sorts of things. And so if they're doing us a favor, we need to make sure that we're very, very respectful of their time. So we suggest ensuring that we plan the event at least, we give them at least about 6 to 8 weeks notice so that we can make sure that they get there. As I said, you should do that with staff as well, but sometimes you can manage to get staff to something quickly if you need to because they're employees. The third thing there is making sure everyone can get to the event. So we don't often think about it when we plan an event for staff. We don't really think about how they're going to get there. We just give them the location and we figure that they can manage. But again, because we're dealing with patients, we do need to think about how they're going to get there and try to facilitate that if necessary. Certainly, especially if we're dealing with seniors, we know that oftentimes when there's lack of adherence to any number of things, and we actually dig down to try to understand why, it's because transportation issues, right? They just can't get different places. So we may need to facilitate them getting there. Lynn just talked about grade 6 English, but this is also about jargon. We don't even realize the amount of jargon that we all use. And again, that creates a barrier because think about it, if we're sitting at a table of providers and patients and we start using jargon, they become uncomfortable and many will be afraid to ask what we're talking about. And again, it's a barrier. The playing field is no longer level. We're in control. They have no clue what we're talking about. And we want equal decision making, equal input. So really important to try to think about what we're saying, and sometimes even when we're trying, it's hard. I'm on a board where the CEO is constantly saying to the staff at the table, I mean, I'm on the board as a lay board member, but I'm in healthcare, and she's constantly, as the staff start talking, saying, and could you please explain what that means? And could you please explain what that means for the people around the table who aren't in healthcare? We just don't realize we're doing it. Staff will often be, and I think Lynn alluded to this earlier, as nervous or sometimes more nervous than patients in the room because it's a new way of working. And it's a new way of presenting yourself in front of people. So we need to do whatever we can as facilitators to make sure that the staff who are in the room and participating with us feel comfortable. And then also try to ensure that staff, I mean, badges are one thing, but staff tend to take over control, particularly if we're sitting at tables like this and there's group conversation. So in a session where you may think that you planned it and you've got, as a single facilitator, you can manage the crowd, sometimes a good idea to have 1 or 2 other people just to help you so that they can circulate in amongst the tables and make sure that everyone, i.e. patients and family members, are getting an equal opportunity to talk and input and engage in the conversation. And then finally, not to leave without an action plan, and that's a basic improvement principle. We never want to leave an improvement event without an action plan that starts to delineate roles and responsibilities and timelines, etc. But particularly, 2 things are important. One is these patients and family members have given up their time, and to be respectful of them, they want to make sure that something's going to happen as a result of them having come in to do us a favor and share in the often intimate ways in which they do. And secondly, we want to ensure that it isn't just the staff who lead with actions, but it's patients, because if they're equal partners on our teams, then we need to make sure that the patients also lead with some action steps. And we'll talk in a couple of minutes about what some of those might be.
Back to your point about the patients in group settings like this and family members, is it better from your experience to have them, say there's like 5 or 6 or 7 of them in the room at a table by themselves, or integrate them into other tables, say healthcare?
I'll answer from my own experience, and then I'll ask Lynne to comment. I've been in a number of events with patients providing input, and I find that they feel very comfortable being integrated in with staff. And we certainly get the most benefit, I think, when they're integrated in with staff.
Yes, certainly I would do that. I think if patients are just together on their own table, they become isolated, and basically we all need to hear what they're saying. But it's that facilitation that's quite important to make sure they're given a voice and that they feel comfortable. But actually, once they do, they're really good. And we forget that patients are like us. Sometimes we have in our mindsets that all patients are very vulnerable and can't speak up for themselves, and that is the case for some of them. But some of our patients have been, lawyers, journalists, mothers who fantastic project managers because they've got 3 children at home and they're looking after an older person, school teachers. Actually, a lot of them just need to feel settled, and they absolutely get their voice and work well. But I'd never just have the patients together. I'd always integrate them but try and support them in the best way.
I've been in a number of events where if you walk into the room, you would never know who the patients were and who the providers are. Question?
Do you ever provide an opportunity for the patients to actually tell their story at the so like each one of them individually gets the opportunity to tell their story to each other?
I'm going to this to Lynne, but it depends on what you're doing, because you can do a variety of things. Sometimes you're actually showing edited film, both from providers and from patients. Other times you've got them in there and starting to co-design. It's beyond that, but you might actually use a story to start off the session.
Yeah, I'd reinforce what Paula says. It depends what you're doing. But yes, we do sometimes. Sometimes we might have a patient-only event as a starting point where we've taken their stories, we've created the map. We want them to reinforce that. We want them to add to it. And having them talking together, they'll add more emotion with some post-it notes. But even at a time with staff as well, sometimes you can do that. The thing you need to do is control the time, because stories they suck you in, because they're so wonderful, and you need to manage it quite well so people don't feel that they're shut down, but you're still able to take them. So, there's a management task around that.
Is there another question?
It was just a comment, because we were talking about the patients and the patients being part of the group, and the question whether having patients be just a table of patients, and I've seen it both ways where it's a critical mass. It's almost like if you don't have enough patients at the table, it's pretty easy. It comes back to the jargon. For the folks who are, it's not a joint discussion. It's we were talking before, a token patient. So making sure there's that particular person who's representing that group, there's either enough of them or they have enough efficacy to be able to hold their own in that table. I've seen it where the group, where the professionals, and this was a board, but it's the same concept. The professionals at that were so easily able to control, and it gave them tension, because the folks were, the community folks were at the table, but they really didn't feel that they were being heard. So you talked about facilitation and making sure that happens.
I was just going to say, that requires really excellent facilitation, not only for the person circulating, but maybe a good idea actually to have a couple of people at the table particularly tuned into that and wanting to try to help to ensure that that doesn't happen.
Or upset the balance by having more patients at the table. That works.
Just going back to your point about using simple English, how do you plan for participants who are ESL, English as Second Language?
So we would, we try and make sure, when you're asking patients to come to an experience event, we're really clear about their abilities or non-abilities with the English language, and we would try and get an interpreter or a family member to come with them. So typically in England, it's the younger family member who's able to speak English, and particularly with older people or seniors, and we'd invite somebody to come with them, or potentially ask somebody from their community, a community member, to come with them. But community members are really fabulously helpful in lots of ways and can come as support and get over the language barrier.
And I've talked to some other people who, in inviting patients, have said they've invited family members as well, not solely for that support, but because they provide an additional, very rich perspective. And the other thing is just to be careful about who we invite, right? We want to make sure that the people who we're inviting can provide good input, but that they're also going to be comfortable, and that you know that they're going to be able to handle and manage it. So there is some thinking that goes into the selection of individuals, and potentially, I mean, it depends on how much involvement you're going to have with them, but sometimes there's some training involved too, some sort of one-on-one training that you can do to prepare somebody to be in that kind of a setting. So we're going to do a little bit that this isn't necessarily distinct or unique to experience-based design, but it's a good practice for any kind of improvement work. And this is about thinking creatively so that we kind of get outside of our box, and rather than solely tweaking the edges, we actually really start to think creatively and think differently. And so I don't know whether, I'm sure some of you have probably seen this. This is just a minute and a half. Oh, darn. Probably not worth it to try and get it up again. How many of you have seen, I'll just share with you what the story is. It's very funny. Go on YouTube and look at it, but how many of you have seen the escalator video? Oh, okay, well, half of you. I'll just share with you. It's apropos to getting outside. You know, if you've ever read about thinking creatively, there are these valleys and ruts that we get into in our thinking, and we need to, if we're thinking creatively and innovatively, we need to get ourselves out of those ruts and think outside the box. And it's a picture of this guy in this massive office building going up the escalator, and it's broken, it's stopped. And he starts screaming out in this massive hall, "Oh my God, I'm late. What am I going to do? Will somebody please help me?" And then there's this woman down below him, and she starts screaming out and saying, oh my God, can't anybody help us? And she said, "Do you have a phone?" And he goes, "No, I don't have a phone. I'm sure somebody will be here soon." And then there's this guy coming in the escalator below, and he says, "I'll be there in a minute to help you." And then that escalator stops, and they all just like scream. It's just, every time I see it, I just laugh. It's like, they don't even think about walking up the darn escalator. They just are standing on there and expecting the darn thing to move down, when they could just pick up their feet and walk up the other half of the escalator, but they just couldn't think of it. So anyways, I wanted to show that to sort of, to make the point. Now let me get this back up. Okay. So, you can use the exercise. We're going to run through a few very short exercises, and you can use this in your own improvement work to get people to thinking differently. One of the things I say with creative thinking is that in order to get some really good ideas, we need to brainstorm a whole slew of ideas, because some of them are going to be discarded. So in order to discard, we've got to make sure that we've got a number to start with, so that once we discard some, there are some left.